So greetings everyone. Welcome to the 239th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Kaleb Abbott. Dr. Kaleb is an optometrist and also currently he is the assistant professor of ophthalmology at the University of Colorado School of Medicine. He is faculty for both the dry eye clinic and also for the Center of Ocular Inflammation, where his most of the time, is spent by looking at complex ocular surface disease patients, as well as he participates in clinical research and clinical trials, which are pertaining to ocular surface diseases. In addition to his clinical and research duties, he is also on the board of directors for the Ocular Wellness and the Nutrition Society. He is the vice chair of the Nutrition, Disease Prevention and Wellness Special Interest Group for the American Academy of Optometry, and also on the advisory council for the American Academic Medical Center in Optometry as well at the AAO. He was selected for the PHOOM Leadership Academy through the AAO, and he will be, taking that through this year as well. And he also recently became the host for the Dry Eye and Ocular Surface Disease section clinical podcast series by the Academy. He also has co-founded a company which is based in the US, which is called Sun Snap Kids. But I think he's now currently focusing more onto his academic and research role at the university, as his main passion is in ocular surface diseases. So thank you so much, Dr. Kaleb, for joining in on this very early Sunday morning for you, and taking us through this very interesting topic about the corneal nerves and its involvement in terms of ocular surface disease. So thank you so much, Dr. Kaleb, and let me just leave the screen time to you, please.
All right. Yeah, thank you so much, Fakhruddin. I am really excited to present today. This is a topic that I'm super passionate about. So our dry eye clinic receives all sorts of patient referrals from Colorado, but also surrounding states in the United States as well. So we're the only academic medical center in our area. So many patients come to us if they don't feel like their eye discomfort is improving. So we see a lot of very challenging ocular surface disease cases and a whole lot of corneal nerve disorders as well. So when I first started in our dry eye clinic, it was not at all what I was anticipating. I thought it'd be just kind of our routine dry eye, and I learned very quickly that we have a disproportionate number of these challenging corneal nerve involved cases. So this kind of became one of my clinical areas of interest and one of my passions. So I'm really excited to present this today and kind of a lot of what I've learned over the last few years. So when we think about the history of dry eye, it really comes down to Sjogren's syndrome. So many decades ago, we thought that the only type of dry eye that existed was Sjogren's syndrome, where we have an autoimmune condition that's attacking our lacrimal glands and that is actually decreasing tear production. And this is kind of where our thinking stopped. We thought, it's just as simple as decreased tear production. But then the problem is all these patients kept coming in and reporting that their eyes felt dry. But then when we did examinations on these people, they didn't actually have dry eye, despite their eyes feeling dry. So then we started to get kind of confused as to what is actually going on here. So we got fancy. We started looking not just at tear production, but at things like tear breakup time and tear film inflammation, ocular surface inflammation, measuring things like matrix metalloproteinase 9 levels, which is an inflammatory biomarker in the tear film. And we started looking at tear film osmolarity. So what's the salt content of the tears? And if that's high, is that triggering some of these patients' symptoms and driving a lot of the ocular surface disease? We started looking at things like lid margin disease, ocular rosacea, meibomian gland dysfunction, blepharitis, and we tried to get a better idea of what's going on. But then all these metrics still didn't actually correlate with dry eye symptoms that our patients were feeling. So we had all these fancy diagnostic tests that we were doing, all these patients saying their eyes felt dry, and we couldn't come up with any sort of test that would explain our patient's symptoms, or that we could correlate signs and symptoms. So I think when we think about dry eye traditionally, we think about it under the umbrella of signs and symptoms. And we say there's either signs of dry eye or there's not signs of dry eye. And then when it comes to symptoms, we have comfort symptoms and visual symptoms. So sometimes patients say, I've got discomfort, burning, redness, light sensitivity, or they're saying I have fluctuating vision. So every time I blink, my vision clears up and then it gets blurry again. So as practitioners, we would then think, do they have signs of dry eye, or do they have symptoms of their dry eye based off comfort, or do they not have symptoms based off comfort? And then same thing visually. So do they have fluctuating vision or constant blurred vision related to dry eye? But I argue that if you think about it just like this, just in terms of signs and symptoms and trying to figure out dry eye or no dry eye, that you'll drive yourself crazy, because as we know, the signs and the symptoms don't correlate at all. So are corneal nerves the missing link here? Can this actually explain why we can't come up with any sort of diagnostic test to correlate signs and symptoms? So the cornea is the most densely innervated tissue in the entire body. There's over 7,000 nerve endings per square millimeter. This makes it about 300 to 600 times more sensitive than your skin. The cornea is also avascular, so it doesn't have blood flow to actually drive nutrients to the cornea. So it depends on the tear film for a lot of that nutritional support. It also depends on the corneal nerves to deliver a lot of the nutritive support to the cornea, and especially to the corneal epithelial cells. So without proper nerve function, the cornea can't actually function. So we'll go over corneal anatomy to begin with. So how is the cornea innervated? Well, we have the trigeminal nerve nuclei that goes to the ophthalmic branch, or V1. That goes to the nasociliary nerves, then to the long ciliary nerves, and finally to the corneal nerves. So there's quite a bit of branching that's happening for this innervation. And then once it reaches the cornea, there's actually about 70 to 80 nerve bundles that are entering the cornea. So if you picture the cornea in a circle, you have about 70 to 80 that are entering radially at the layer of the stroma. So it's about midway through the cornea. It will lose its myelin sheath at that point, but keep the Schwann cells, and it will travel to the anterior 1/3 of the stroma. There, it's going to lose the Schwann cell sheath, and then it's going to form a plexus. So we call this the subbasal nerve plexus, and that's located, again, at the anterior 1/3 of the cornea. So this is a structure that we really can't see whenever we're looking with our slit lamps, but that really, really matters here with our patients. And then the nerves will continue to course anteriorly towards the front of the cornea, and then it'll actually divide into fine branches between those basal cells. And there's different fiber types that are present in the cornea. So we have different nerve pain receptor types, and we have also different fiber types. So there's the alpha fiber types, which are the myelinated ones, large diameter, and that actually go to the corneal surface. And then there's the C fiber types, and these are the ones that are mostly associated with pain and discomfort. These are smaller beaded fibers with no myelination, and they become free nerve endings. And these are the different nociceptor types. So nociceptor just means pain receptor, and we have 3 different types on the cornea. And I think that this is important for us if we're going to understand what's actually driving our patient's symptomology. So what are these pain receptors actually detecting? Well, we have polymodal nociceptors that detects mechanical, chemical, and heat stimuli. Then we have mechanonociceptors that only respond to physical touch. And then the most interesting one is the cold thermoreceptors. And this one is primarily driven by the C fiber types. And it's actually detecting a cooling of the cornea. So when your tear film begins to evaporate, when you get about a 1 to 2 degree temperature shift of that cornea as those tears evaporate, it will actually trigger that cold thermoreceptor to fire. The cold thermoreceptors also detect tear osmolarity. So if there's too much salt in the tears, it'll cause that cold thermoreceptor to fire and trigger symptoms in our patients. And it actually gets a little more complicated in this because each of the different nociceptor types or pain receptor types have specific ion channels that lead to the firing of that pain receptor. So the notable ones are TRPV1, that's mostly associated with polymodal nociceptors, and then TRPM8, that's mostly associated with cold thermoreceptors. And that's important because in the future, there's going to be drugs developed that are specifically targeting these ion channels within those pain receptors. So physiologically, we think about the corneal nerves as impacting, the sensory component, so detecting our patients being able to detect if something's in their eye or if they should have discomfort. There's a blink reflex, so you get a foreign body in your eye, it causes you to want to blink, and then we have tear secretions. But we oftentimes aren't thinking about the trophic functions of the cornea, and the trophic is essentially that nutritional support that those corneal nerves are bringing to the cornea. So this gets actually quite complicated, but there's a lot of homeostasis involved here. So we have corneal sensory nerves. So the actual corneal nerves release neuromediators like substance P that actually provide nutritional support to the epithelial cells. So the nerves are supporting the corneal epithelial cells. And then in return, we have the epithelial cells that release neuropeptides, neurotrophins, and a nerve growth factor that actually supports the nerves. So the nerves are trying to help the epithelial cells by secreting all sorts of different factors, and the epithelial cells are trying to support the nerves by secreting all types of different factors. And then additionally, we know that the nerves, whenever the eyes become dry or you get something in the eye, the nerves will tell the lacrimal glands to secrete tears. And then the lacrimal glands then also deliver all sorts of nutrients and things like that to help nourish the epithelial tissues. There's a true homeostasis that's happening here. And when we think about the lacrimal gland secretion, so the water portion of the tears or the aqueous portion of the tears, we can't just think about this as water because there's so much more to it than water. There's actually over 2,000 unique protein molecules inside the tear film. There's vitamins, there's minerals, there's nutrients, fibronectin, lysozyme, nerve growth factor, all these different things that are supposed to help out the corneal epithelial cells. So this just kind of gives a broad overview of all that's involved and how complicated it gets between the sensory nerves, the epithelial cells, and the tear secretions from the lacrimal glands. So with all of this happening, why aren't we thinking about the corneal nerves with every single patient that we're seeing? Well, I think that we forget their role in ocular surface homeostasis because we can't actually see them. So picture there is a very prominent corneal nerve, but aside from being able to catch just rare glimpses of corneal nerves, we can't actually see that subbasal nerve plexus or all those fine nerve endings just with the slit lamp. Whenever we image them in our clinic, we're actually zooming in 600x on the corneal nerves, and our slit lamps only go to 40x. So we can't actually see them very well clinically. But then it also gets a little bit more complicated than this too, because we were just talking about the corneal nerves, but that trigeminal nerve actually goes all the way through the first order, second order, then third order neurons. So it's actually going from the eye all the way down to the upper spine. So about C1 to C3 of the spine, and then up into the brain system to the thalamus there. So this is how you can actually get eye pain that's related to neck pain, because if something's impinging or affecting the trigeminal nerve in the neck, you can actually get what's called referred pain that is presenting symptoms of dry eye or symptoms of eye discomfort to your patient, even though the original problem is in the neck. We call that cervicogenic eye pain. So to understand dry eye, I think we really have to try to understand what type of pain our patients are experiencing. And there are multiple types of pain here. So pain is defined as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. So when it comes to the eyes, we can think of dryness, we can think of burning, sandiness or grittiness, and then sharp pains or like pins and needles. And there's different types of pain. So we'll go over nociceptive pain, which is kind of what we were talking about before with the nociceptors, neuropathic pain, and nociplastic pain. So when we think about nociceptive pain, this is what most of us are thinking about when we think pain. So this is pain that arises from actual or threatened damage to the body. So if you look at that nail there that's penetrating into the skin, so even if it was just poking the skin, it's not actually causing damage, but it's a threat to the skin. So you would actually have pain receptors that are firing, probably those mechanonociceptors that respond to touch would be firing. And then if it penetrates into the skin, then that's actual damage that's occurring. So this is due to activation of nociceptors. So this is the classic form of pain. It should be transient in nature. Non-ocular examples would include like trauma. So if you wake up in the middle of the night, you're trying to find the bathroom and you run into a table and you hit your leg on the table, then that's going to be nociceptive pain. There's also things like surgery and tissue inflammation. So this is classically what we think about when we think of pain, but there's different types of pain besides this. So then we can have peripheral neuropathic pain. So this is pain caused by a lesion or a disease of the somatosensory nervous system. So this is essentially the nerves just becoming hypersensitive. So examples of this is diabetic neuropathy, postherpetic neuralgia, and chronic postoperative pain. So with diabetic neuropathy, that disease attacks your nerves, and you can actually have feet that become super, super painful, even though there's nothing wrong with the foot. The foot is in lots of different pain, or lots of pain. And that can happen to the feet, that can happen to the hands. But if you think about it, it can also happen to the eyes as well. It can happen anywhere in the peripheral nervous system. Then we think about postherpetic neuralgia. So something like a shingles or varicella zoster attack that happens, to one half of your face. Even after you resolve that with oral antivirals, you can still have the residual pain because it has damaged the nerves inside the face. And then chronic postoperative pain. We see this in cases like LASIK and cataract surgery. And then the last type is by far the most confusing type. So this is central neuropathic pain. We call this nociplastic pain. So this is pain that a patient's experiencing despite no activation of the nociceptors and no evidence of a disease or a lesion of the somatosensory system. So this is really dysfunction of the central nervous system and the pain processing centers of the brain. So when we think about nociceptive pain, that could be something like Sjogren's syndrome, could be ocular rosacea, could be glaucoma drops that our patients are having to chronically use, or it could be anatomical. So you could have like an eyelash that is poking you in the eye. Then peripheral sensitization, so peripheral neuropathic pain, could happen due to LASIK, cataract surgery, or chronic inflammation. So this is something that's happening that can damage those corneal nerves. So in LASIK, you're actually severing a lot of those corneal nerves and hoping that they regrow. Cataract surgery, you do that to some extent too, or just chronic inflammation can damage those nerves. And then we have central sensitization. These are things like chronic pain syndromes, fibromyalgia. Migraines is arguably just a different type of neuropathic pain, and things like traumatic brain injury. But the problem is that if nociceptive pain hangs around long enough, it can actually sensitize those peripheral nerves. And if the peripheral nerves become sensitized and you don't treat it, then it can actually lead to central sensitization as well. So this is why we have to treat dry eye aggressively at the beginning. Otherwise, it can lead to a peripheral neuropathic pain, which can then lead to a central neuropathic pain. But then it actually gets a little more confusing than this. Let's say you have neurotrophic keratitis. So neurotrophic keratitis is when those corneal nerves don't work at all. But then you can actually have conversion of some of the fiber types to a different fiber type. So you can actually get conversion from those A fiber types to those C fiber types. And remember, A fiber types are mostly dealing with physical touch, like mechanical stimulation, and C fiber types are mostly dealing with pain. So you can get mechano-based fibers that actually convert to pain-type fibers, and then your patient can get neuropathic pain. So essentially, they can have corneal nerves that aren't working well, but still be in a lot of different pain. And this is why you can have patients that corneas look like this, and they say, my eyes hurt. And you say, well, that makes sense. That eye looks like it should hurt. But then you could have a cornea that looks like this, and that patient says, well, my eyes hurt too. And you say, well, that doesn't make any sense because that doesn't look like a cornea that should be dealing with any sort of eye pain. And the first would be a nociceptive pain, like a typical dry eye. And the second would be a neuropathic pain. So something is wrong with the nerves, and those nerves keep firing even when they shouldn't be firing. But then you can also have a patient whose eyes look like this, and they say, my eyes feel great. And that would be an example of a neurotrophic keratitis. Those corneal nerves are not telling the pain processing centers in the brain how much that eye should be feeling pain. So all this is to say that signs don't equal symptoms. So we must consider corneal nerves when we're treating dry eye. So the way that I like to think about it is this sort of graph here. So on the x-axis, we have ocular surface status. So what I'd say is that red is bad on the x-axis and green is good. So the red would be when there's corneal staining involved and it looks dry. And the green side would be when there's no dry eye. So the ocular surface looks fine. Then on the y-axis, we have pain status. So the red would mean increased pain, and then the green at the bottom would mean decreased pain. So we can have typical dry eye. So that would be here, where you would see on the ocular surface status that there is corneal staining involved. So it's on the red side, so that's bad. So corneal staining. And then at the top, where there's pain status, you see that patient's in pain. And to us, that makes sense. The eye is dry and the patient feels it. So that makes sense. Then we have no dry eye down here. So this would be there's no corneal staining and the patient doesn't feel pain. So that also makes sense. That'd be no dry eye. But a lot of times as practitioners, we stop here and we don't think, well, what if there's something else that could be going on? What if my patient presents over here? So this would be where the ocular surface looks bad. So it's in the red side. And yet that patient is not reporting any pain. So their pain status is good. And that would be an example of a neurotrophic keratitis. And then over here in the top right would be neuropathic pain. So this is when the ocular surface status overall looks good. So there's no corneal staining, yet that patient is still reporting pain. So that would be a neuropathic type of pain. The problem is we don't know where our patients are going to be entering whenever they come into our office. They could be coming in at any point, and it's our job to try to figure out where they actually are. So if we back up, we need to ask, well, what actually predicts whether or not our patients are going to have any sort of eye discomfort or dry eye? So, or any dry eye symptoms, that is. So these are the greatest predictors for whether or not our patients are going to be experiencing dry eye symptoms: the presence of a chronic pain syndrome, anxiety, depression, psychiatric disorders, sleep disorders, and things like stress. These are by far the top predictors of whether or not our patients will be experiencing dry eye symptoms. So dry eye is extremely associated with depression and anxiety. It's associated with poor perceived health status and health anxiety. So these patients will come in thinking that not only are their eyes dry, but that overall systemically they're not doing well, that they feel like they're sick, even though they're actually doing quite well oftentimes. And then it's also very associated with sleep disorders. So I do another talk where I talk about, all the ways that poor sleep can lead to dry eye, but also how dry eye can lead to poor sleep. So dry eye is more associated with these three conditions, or these three things, so depression, anxiety, poor perceived health status, and sleep disorders, than any other ocular condition. We also know that in asymptomatic versus symptomatic dry eye patients, that scores for depression and anxiety are significantly worse in the symptomatic group. And then fascinatingly, if you treat dry eye, it actually reduces anxiety and depression levels. Then on the flip side, if you treat anxiety and depression, it can actually improve the success of dry eye treatments, which is actually counterintuitive to what we were taught in school, because we know that anxiety and depression medications negatively impact lacrimal gland secretion. So you actually get reduced tear secretions. However, it somehow improves our dry eye treatments. And the reason it's doing that is because it's impacting the peripheral nervous system and the central nervous system. So we're actually able to improve dry eye treatments even when we're making the eyes drier. So all this is to say that dry eye is a lot more complex than we actually believed. So if you have patients that are coming in and their eyes look fine, yet they're in all sorts of pain and discomfort, there's really two different beliefs as to what's happening here. So the first is that all symptom reports involve perceptions that accurately represent reality. The other way to think about it is, well, this patient has so many symptoms that it's impossible to believe that everything they're saying represents reality, especially because there's no objective basis for them. So we would call these patients malingers or hypochondriacs. But the problem is that we now have objective evidence of eye pain that we can see through confocal microscopy. So this is actual corneal nerve images, so zoomed 600x onto those corneal nerves. And this is a patient of mine that had a peripheral neuropathic pain, and her corneas looked totally fine. She had no evidence of dry eye, but she was in debilitating eye pain. And everyone had told her she doesn't have dry eye. Her eyes are totally fine. But then when we zoomed in 600x on the corneas, this is what we see here. And those balls there are called microneuromas. Those are essentially severed nerves that keep misfiring and misfiring and misfiring, that cause a whole lot of pain in our patients. So with confocal microscopy, when we zoom 600x on those corneas, we can see decreased nerve density, microneuromas or hyperreflective foci, and in cases of tortuosity, nerve beating and nerve sprouting. This patient here had a PRK surgery, so a laser surgery of the cornea to fix his vision. And the surgery went great. He was seeing very, very well, had no signs of dry eye afterwards, but was in horrible, horrible eye pain. And this is what his subbasal nerve plexus looked like, those corneal nerves when we zoomed in, that's 600x. So this kind of shows us that we need to rethink dry eye. It's not as simple as, is there corneal staining, is there ocular surface staining, is there meibomian gland dysfunction, but there's a huge role of these corneal nerves here. Now, neurosensory abnormalities have been recognized as a potential contributor to dry eye since 2017 as defined by TFOS, but nerve abnormalities are often missed. And in the cases of quote unquote dry eye, we often fail to consider comorbidities such as anxiety, depression, sleep disorders, mental health status, and chronic pain syndromes. So you might say, well, how are all these corneal nerve disorders arising? And I say, well, how do corneal nerve disorders not arise? Look at all these risk factors that our patients have. Some of us live in dry climates, which chronically can cause ocular surface disease. We're exposed to pollution every single day, especially those of us that live in urban settings. There's UV light exposure, and our patients aren't always wearing sunglasses outside, and that UV light can cause damage. And then there's things like surgeries. This is a huge one. So when you look at the LASIK picture over there on the right, we're actually severing 270 degrees of those corneal nerves. And then we're praying to God that those corneal nerves are going to regenerate. And corneal nerves regenerate at about 1 millimeter per month. So after a LASIK surgery, your nerve should regenerate in probably about maybe 6 to 12 months or so, but it doesn't always. And those are the cases where patients can become suicidal after LASIK because their nerves aren't regrowing back normally, and their nerves just keep misfiring and misfiring and misfiring, causing them all sorts of eye pain. Then there's systemic medications that lots of our patients on that dry out the eyes and cause chronic inflammation. Topical medications, this is a huge one. So every single glaucoma medication that exists dries out the eyes in at least one way. Most glaucoma drops have 3, 4, 5, 6, 7 different mechanisms of action for how it's actually drying out the eyes, whether it's damaging the goblet cells that produce the mucin, or it's damaging meibomian glands, or it's decreasing meibomian gland secretions, or it's just causing low-grade chronic inflammation. It can also decrease lacrimal glands. It can BAK, which are the preservatives inside most of these glaucoma drops, benzyl alkonium chloride, is actually toxic to trigeminal nerve endings. So there's so many ways that these drops are causing corneal nerve damage. And there's chronic medical conditions like diabetes that attacks the nerves, and things like shingles and all sorts of small fiber neuropathies that our patients can have, and then chronic ocular conditions as well. So just chronic ocular surface disease, ocular rosacea, blepharitis, herpes simplex, herpes zoster, things like that. So there's so many risk factors that our patients actually have for this corneal nerve damage. So when we think about a neurotrophic keratitis, we're thinking about this quadrant down here. So when you look at the pain status, so the y-axis, so the up and down portion. This patient, it's in the green, so they're not feeling symptoms of discomfort. But then when you look at the ocular surface status on the x-axis over there on the left, it's red, so that means that there's corneal staining. So there's corneal staining, and the eyes are desiccated and dry, but the patient doesn't feel it. So that is a neurotrophic keratitis. So neurotrophic keratitis, the estimated prevalence is about 16 out of 100,000 patients, and it can stem from the corneal nerves, the ocular nerves, trigeminal nerves, the central nervous system, systemic disease, genetic conditions, a whole lot of different areas. Now, the top causes, this is what matters most to us. Herpetic infection is by far the top cause for neurotrophic keratitis, most of which are simplex, but it can be zoster as well. Intracerebral tumors or neurosurgery is a big one, especially in our clinic, because I work in a hospital-based setting. So we get referrals all the time from neurosurgery. They did some sort of a surgery, and then the patient after the surgery is saying that their vision's blurry. They're usually not in discomfort. Their vision's just blurry because they can't feel just how dry their eyes are. And they come into our clinic and we diagnose a neurotrophic keratitis. Topical medicamentosa, usually that's from glaucoma drops or drops that have benzalkonium chloride in it. Chronic blepharitis or ocular rosacea, and then diabetes is another really big cause of neurotrophic keratitis, again, because it damages those peripheral nerves throughout the entire body. So when we go to classify it, stage 1 just looks like dry eye, just a bunch of those fine punctate keratitis spots. Stage 2 is when there's an epithelial defect. And then stage 3 is when that defect actually starts to thin. So you get a neurotrophic ulcer, so thinning and stromal involvement. Now, stage 1 versus dry eye. This is a question that I get asked about all the time. Is this dry eye or is this stage 1 neurotrophic keratitis? It's very difficult to discern the two unless you're checking corneal nerve sensation, because stage 1 symptoms are a lot like dry eye. Those nerves are still firing to some extent, so the patients can still feel a little bit. So they'll feel irritation, foreign body sensation, maybe have some blurred or fluctuating vision and light sensitivity. And then the signs are very symptom too. That just looks like dry eye. But we have to remember that with stage 1 neurotrophic keratitis, there also has to be dry eye because those nerves aren't working well. So you're not going to blink as much as you should be blinking. And you're going to have reduced tear secretions as well because the nerves aren't telling the lacrimal glands to secrete tears. So 100% of stage 1 neurotrophic keratitis cases, there will also be dry eye as well. Now, when it comes to neurotrophic keratitis, we have to understand that comfort actually is going to improve as the severity of neurotrophic keratitis gets worse. So when you think about it, the worse those corneal nerves are, the less patients are going to be able to feel those symptoms. So when you get to like a stage 2 or stage 3, these patients aren't feeling any symptoms at all. Their eyes feel great because those corneal nerves can't tell the brain just how damaged that cornea is. So that's something to think about as well. So with stage 2 and stage 3, usually the eyes actually feel pretty good, but you'll have increased symptoms of blurry vision. So they now won't be coming in saying, my eyes hurt really bad. They'll come in saying, my eyes are blurry. So that's something for us to understand too, because again, those corneal nerves aren't telling us just how damaged that cornea is. Now, the hallmark of neurotrophic keratitis and the way that we diagnose it in clinic is the reduction of corneal sensation. You have to do this sort of testing in office to figure out if it is a neurotrophic keratitis. So I'll give you an example of how this could present in your office. So, and just to kind of explain how these patients don't feel symptoms, I've had several patients in the last year that have come in to see me and they've said, I've got this white dot on my cornea, which is never a good sign. But they said that my eye feels great. I just can't see. And I've got this white dot here. And I go to look underneath the slit lamp and they have a raging bacterial infection of their cornea. I mean, one of those things that should be causing unbelievable eye pain, but they're not in eye pain because they can't feel it. All they're coming in is saying, I just have blurry vision. In one of those cases, she had actually had a corneal perforation. So she had an open globe. Her cornea, the infection had broken straight through the entire cornea, and she still couldn't feel it at all. And we had to rush her off for surgery right then and right there. So these patients, it's a big problem because they don't feel all the pain that they should be feeling. So when should we be checking corneal nerve sensation? Well, when traditional dry eye therapies have failed, when there's a lot more signs than there are symptoms, if the cornea has an irregular epithelium or a little edema to it, especially like a microcystic edema, and if the patient has any risk factors for neurotrophic keratitis, that's when we need to check corneal nerve sensation. So aesthesiometry is the fancy term for sensation testing. So what is corneal sensation testing? This is assessing a patient's reaction to a brief corneal stimulation. This gives us functional insight into the status of those corneal nerves. So if we're poking the patient in the cornea with something, we're directly testing those mechano-nociceptors and the polymodal nociceptors, because those are those nociceptors or pain receptors that detect physical touch. So we can see if the patient's response to that is absent, reduced, normal, or if they have increased sensitivity. And if they have less sensitivity, so it's absent or reduced, and they're not feeling whenever we are touching their eye with like a cotton wisp or dental floss or something like that, then that's diagnostic for neurotrophic keratitis. And if they feel it more than they should feel it, that could indicate a neuropathic pain. Now, a lot of like academic centers, like where I work, we do quantitative testing. So I actually use the Cochet-Bonnet, which is pictured at the top there. It's like this metal cylindrical tube with almost like a fishing line inside it. And I can actually measure just how long of a filament length it takes for my patient to feel a stimulus. But then there's also different things like Belmonte's gas aesthesiometer, or Brill just came out with a new aesthesiometer based off an air puff and how strong that air puff is. But most people don't use this because it's really expensive. It's hard to maintain sterility. But there are, some good things about it. You get objective data, you have established norms, and it's easier for bilateral cases. But it's mostly used for research. What most people are doing in clinic is qualitative testing. So this is like a cotton swab, dental floss, or tissue paper, because it's cheap, it's readily available, doesn't really take a whole lot of training, and doesn't take a whole lot of time. The downside is it's a little bit subjective. You have to kind of test sensation on a bunch of eyes before you understand, whether or not your patient should be feeling this or not. It takes a little bit of experience. It's also difficult for bilateral cases. So both eyes are involved. Now you can't test the quote unquote good eye and then test the bad eye to see if there's less sensation there. And so when both eyes are involved, it's a little harder to diagnose. So how do we test corneal nerve sensation? I mean, it's a very simple test, but we need to make sure we do it right. So you ideally want to start with the eye that you think is unaffected. And you want to ask the patient when they feel it, not when they see it, but when they feel it. You're going to take something like a cotton wisp or dental floss, and you're going to approach them laterally, so like by their ear, tell the patient to fixate straight ahead, and then you're going to touch their cornea in the center and kind of assess centrally. Then you also want to do the other quadrants, so superior, inferior, nasal, temporal, and then observe the patient reflex. So you want to see, are they blinking? Are they saying they feel it? Are they blinking? Are they pulling back a little bit? You want to see how that eye actually responds. Then you want to check the other eye. And then you can document if their response is absent, reduced, normal, or increased, or you can just grade it, like on a scale of 0 to 3. A lot of people are starting to push for a grading system. I usually just describe it as absent, reduced, or normal. And then how do you document it? So this is a kind of example of a patient that I had that had a shingles infection, and it caused an iritis, like a uveitis. They were seen in our uveitis clinic. And then about 2 months after being seen in the uveitis clinic and having it completely resolved, the uveitis specialist referred to me for suspected neurotrophic keratitis. And they came in to see me, and they had a stage 2 neurotrophic keratitis. They had an epithelial defect. So the top is kind of what it looked like before. The bottom is what it looked like when the patient saw me. So I tested the unaffected eye first, which was the left eye, and the corneal sensation was normal. And then I tested the affected eye, so the right eye, and it was definitely reduced. I said that this is a stage 2 neurotrophic keratitis with an epithelial defect, and then we treated it as such. So when you treat neurotrophic keratitis, there's a lot of debate as to what you're really supposed to be doing here. Like, what's the actual goal? The original school of thought proposed by Dr. Mackey was that you don't really do much except supportive therapy until stage 2 or stage 3, because stage 1 is just kind of like dry eye. And then stage 2 or stage 3, these patients are at risk for permanent vision loss or getting an infection. I disagree with that, though, because I think that we need to treat stage 1 aggressively as well. But at bare minimum, with stage 1, we need to be doing supportive therapy, like preservative-free artificial tears, warm compresses, punctal plugs. You could do bandaged contact lenses or scleral lenses, or things like topical immunomodulators like a cyclosporin, just to reduce inflammation and decrease the chances of it progressing. But there's a difference between supportive therapy and restorative therapy. So supportive therapy, you're just trying to prevent it from progressing. But restorative therapy, you're actually trying to help heal those corneal nerves. This can be things like amniotic membranes, autologous serum eye drops, so eye drops made from your own blood, platelet-rich plasma, also another blood-derived product, or a recombinant nerve growth factor. So my go-to is to put an amniotic membrane on the eye, and then order recombinant nerve growth factor. It usually takes about 4 to 6 weeks to come in, and then I'll have removed the membrane by the time that drug arrives, and then we'll actually directly be putting nerve growth factor onto the cornea to try to help heal those nerves. Okay, so on the flip side, we have neuropathic ocular pain. So this is the exact opposite of a neurotrophic keratitis. Neuropathic ocular pain is up here in the top right. So again, if we look at the ocular surface status on horizontally, so on the x-axis, we see that these patients, it's good. Green is good, so there's not a whole lot of signs of dry eye. But then if you look vertically or on the y-axis at the top, you see it's red. So these patients are in pain, even though their corneas and ocular surface actually looks okay. So it'd be cases like this. And then I included that eyeball there that's actually kind of in the dry eye section, because there's no reason that you can't have both dry eye and a neuropathic pain. But the key here is that the symptoms are greatly out of proportion with the signs. So you can definitely have dry eye and neuropathic pain. But remember, maybe it's a little bit of dry eye, but the patient is in a lot of discomfort. So they could have, a component of both. So these are patients that can present to your office with the classic pain, but no stains. They could have eye pain, eye aches, light sensitivity, intense burning, or pain radiating from the eye, like of the eyelids or of the face. But then you look at the eye and you say, well, it looks totally fine here. So the terms that we have to understand here, allodynia, so this is like when patients come in and say, light kills my eyes. And they could be talking not just about like the sun, but like a computer monitor or just an indoor light. And they say, light kills my eyes. So this is pain from an innocuous stimulus. So something that shouldn't cause pain is causing pain. Something, again, like just a cell phone light. So that would be a photoallodynia. So light that's causing pain that shouldn't cause pain. You could have a cold allodynia. So like when they go outside and it's cold, that causes eye pain when it really shouldn't. Or a tactile allodynia. I had a patient that came in and she told me that if she lightly touched her upper lid, just lightly touched it, just for a second or two, her eye would be in pain all day long. So that would be like a tactile or mechanoallodynia. So this is so if you look at the x-axis here, that's the stimulus intensity. So there's really no intensity to the stimulus. And then the y-axis is pain. So the patient should be down here where it's a small stimulus not causing pain. However, the patient is up here. It's a stimulus that shouldn't cause pain that somehow is causing pain. And then the second term to understand is hyperalgesia. So this is increased response to a stimulus. You can have something like wind, where the patient says, I'm so sensitive to wind. And wind should be causing some amount of discomfort in our patients. But in these patients, it'll cause a ton of discomfort. So a disproportionate amount of discomfort with a stimulus that should only cause a little bit of discomfort. There's also some other terms here like wind up. So this is repeated exposure to a stimulus increases pain over time. So maybe when they go out and it's cold outside, they say, well, I can tolerate it for like 5 minutes, but then, 10, 15, 20 minutes, an hour out there, my eyes are killing me. And then prolonged pains. This is kind of like what that patient was telling me. When she touched her eyelid a little bit, she would be in pain all day long. So this is continued pain even after you remove a stimulus. So what are risk factors for neuropathic ocular pain? Well, the top ones are chronic ocular surface disease, chronic pain syndrome, fibromyalgia, chronic fatigue, small fiber neuropathy, migraines, trigeminal neuralgia, irritable bowel syndrome, prior surgery, or trauma. So a lot of this is systemic problems. So systemically, these patients are in pain, and then ocularly, these patients are in pain. Now, interestingly, there's a great study done at the University of Miami by Anat Galor, who's kind of a hero of mine. But she took two different groups of patients. So they had equal dry eye signs in group 1 and group 2. But group 1 had a chronic pain syndrome. So some sort of chronic pain in the rest of their body, whereas group 2 did not have a chronic pain syndrome. So both groups had equal amounts of dry eye, but one group had chronic pain syndrome, the other did not have a systemic chronic pain syndrome. And in the chronic pain syndrome group, they had worse dry eye symptoms and worse evoked pain. So that kind of was a study showing that there's something, again, going on more than just dry eye. It's how is your brain and how are your corneal nerves interpreting the dry eye. So although these disorders manifest in different parts of the body, they're often found to coexist and are likely tied together by a unifying pathophysiology and neuropathic mechanisms. I tell my patients pain travels together. So if you have neck pain, you could have eye pain. If you have this other chronic pain elsewhere, head pain, you could also have eye pain. Another way to think about this is that dry eye symptoms could actually be a peripheral manifestation of a systemic disease. So you might say, well, what in the world is going on here? This is kind of crazy, and this is all new to me. Well, picture that ion channel. So this is that ion channel for that nociceptor, so that pain receptor. And then just picture that there's all these inflammatory mediators that have been sitting and pooling on the ocular surface over time. That can actually sensitize that nociceptor. And when you have sensitization, you have this maladaptive neuronal plasticity, and then that nociceptor just keeps firing and keeps firing and keeps firing, causing that pain. So you can get spontaneous firing of those nerves. You can get a more excitatory neurotransmitter release, enhanced conduction, increased responses, nerve sprouting, nerve rewiring. And remember, you can get conversion of those non-nociceptive fibers, those A fibers that are supposed to detect a physical touch, but they can be converted to those C fibers that actually feel pain. Even though there's no pain or no stimulus there, those C fibers can be firing spontaneously, causing pain in our patients, even though there's not actually a stimulus that's there. And then we have central sensitization too. So you actually have these ascending and descending pathways. And the ascending pathways going towards the brain are modulated by these descending pathways. So you actually are supposed to have these descending pathways that are stopping the ascending pathways from sending all these pain signals. But in neuropathic pain, you get inhibited ability for those descending branches to stop the ascending branches. So this actually creates a negative feedback loop. So you get the reduced descending inhibitory pathways, which causes an increased pain perception and a chronic pain state. So nothing is stopping the pain signaling from the eye to the brain. And you just have this constant cycle where the patients are just constantly feeling pain. Then you get pain even after the stimulus is gone, changes to the central nervous system, and a disproportional perception of pain. So what should you do if you suspect that your patient has neuropathic pain? Well, we need to figure out, does our patient have allodynia, so pain when there shouldn't be pain? Do they have hyperalgesia, so an exaggerated pain response, something that should cause a little discomfort is causing a lot of discomfort? Are their symptoms way out of proportion with those signs? Now remember, there can be coexisting dry eye. Do their symptoms fail to improve when they close their eyes? If you close your eyes, that's kind of the best treatment for dry eye. I mean, you're preventing exposure to the air and things like that. But these patients will say, even with their eyes closed, they're in lots of pain. And do they have any risk factors? Another thing you can do is use proparacaine to try to tell where in the world this pain is coming from. So this is a test that we do in office all the time. This is called proparacaine testing. So we take the amount of baseline pain and light sensitivity that these patients have. We put a drop of proparacaine into both eyes. We don't tell them what the drop is. Then 60 to 90 seconds later, I'll ask them again, okay, well, now how much pain are you in? Now how much photoallodynia or light-causing pain that shouldn't cause pain are you in right now? And if it's the same amount of pain, well, then you would say that doesn't make any sense. I put a numbing drop in your eye and you're still in pain. So it should have gotten rid of the pain. Well, that's evidence of a central neuropathic pain. So that's not happening at the level of the eye. That's happening further upstream, more in the level of the brain. Then if they get decreased pain with proparacaine, which is what you would expect, you expect that if you put a numbing drop in the eye, it should decrease pain. Well, then it could be nociceptive, so it could be dry eye, or it could be a peripheral neuropathic pain. And it's your job as the doctor to figure out which one it is. Is it dry eye, or is it those corneal nerves firing when they shouldn't be firing? Now, can a patient have peripheral neuropathic pain and central neuropathic pain at the same time? Yes, it's actually quite common. So let's say you put a drop of proparacaine in the eye and you ask the patient, well, how much did that improve your pain and light sensitivity? They said, I got about a 60% improvement in pain and about a 70% improvement in light sensitivity. Then you'd say, okay, well, it's about 60 to 70% peripheral neuropathic, and then maybe about 30 to 40% central neuropathic. So you can have both at the same time. Now, treating neuropathic pain, we have to treat nociceptive pain first. This is the general rule of thumb. If you're treating any ocular pain disorder, you have to treat the dry eye first. If you don't get the dry eye controlled first, then it's going to exacerbate their chronic pain state. So treat their dry eye first before addressing the corneal nerve problem. So ask patients what their symptoms are. What is making their eyes worse? Is it wind? Is it light? When did it start? Did it seemingly start after they had a brain injury? Maybe they got into a car accident and had a brain injury. Then all of a sudden they got eye pain afterwards. Did it happen maybe after they had LASIK or after they had cataract surgery? Did it happen after they started chemotherapy or had a burn to the face? Or did it happen after a shingles infection that attacked their face and their eyes? So try to understand the history and the timeline, and then try to tell through proparacaine testing, is it central? Is it peripheral in nature? Is it one eye? Is it both eyes? And what risk factors do they have? And then set expectations with these patients, because there is no cure for neuropathic ocular pain. Now, if it's a peripheral neuropathic pain, so we're saying this is at the level of the corneal nerves, then we have to first treat the dry eye. Second, the things that we can do is high concentration autologous serum eye drops. So these are, again, eye drops made from your own blood, and you essentially just don't dilute them very often. So my go-to is to do 50% concentration blood eye drops, so autologous serum eye drops, mixed with a strong topical immunomodulator, like a really strong cyclosporin, or I'll prescribe a very, very weak steroid with that high concentration autologous serum. And what we're trying to do here is we're trying to use that nerve growth factor that's naturally present in our blood and actually put it directly on the eyes and see if we can heal those corneal nerves and help them regrow normally. I tell patients expect to be on this treatment for at least a year, but you may start to have improvements as early as maybe 4 to 6 months in. And we do know that you can remodel that subbasal nerve plexus and you can regrow healthy nerves by doing this combination of treatment. You could also do things like punctal plugs to hold more tears on the eyes. Remember, your natural tears have nerve growth factor in them. So if you can use a punctal plug to hold those tears on the eyes, then you could get more nerve growth factor to the cornea. You just have to make sure you've treated the inflammation first, because we don't want to hold inflammation on the eye. IPL is good. Scleral lenses, FL41 glasses, or those tinted glasses that help with light sensitivity. You could do supplements like alpha lipoic acid. or tryptamate stimulating compounds. So that would be menthol. I don't know if you'll have access to menthol drops, but we have some here that are just over the counter. And it'll stimulate the tryptamate pathway, and it provides like this cooling sensation on the cornea. And that could be a good option to kind of distract them from the pain. Now, if it's a central neuropathic pain, it's difficult because you can't really put something on the eye to treat a problem that's further upstream along the trigeminal nerve or in the brain. So topical things don't work as well. So systemically, these patients can get alpha-2 gamma ligands, opiate antagonists, SNRIs, now I'm forgetting what the A stands for, but TCAs, anti-epileptic medicines. The only ones of these that I prescribe for my patients are the top ones. So pregabalin and gabapentin. And I'll prescribe that oral pain medicine for the patients, just a very, very low dose, very weak, but knowing that it can help reduce pain that's originating from the nerves. I'll do a low dose naltrexone a little bit, but I don't do anything like duloxetine and nortriptyline or topiramate. There's just too much risk there for side effects. So if it's getting that bad, I'm generally I'm generally co-managing with a pain specialist or a neurologist. The pain specialist I work with will do nerve blocks. So he'll inject methylprednisolone or bupivacaine into those trigeminal nerves to try to get those trigeminal nerves to quit firing. So he'll inject supraorbitally and infraorbitally, and then usually just along the V1 distribution of that trigeminal nerve. So if I determine it's central neuropathic pain, I typically prescribe pregabalin, and then I send off to a outpatient anesthesiologist who does those nerve blocks. You could do a TENS unit, so transepidermal neural stimulation. This is used for migraines, but it could also stimulate the trigeminal nerve, and essentially, if you stimulate it enough, you can almost like reset it so that trigeminal nerve doesn't keep misfiring. Botox is sometimes helpful, not usually, but it can be helpful. And then FL41 tinted glasses, those tinted glasses to reduce the light sensitivity. So I'm generally asking patients if they have associated migraines and light sensitivity, and if they do, then I'll recommend those tinted glasses. We also need to acknowledge the emotional component of eye pain, though. This is something that as optometrists, we don't like to talk about. We're not really trained to talk about this, but a lot of the very pathways that are going from the eyes and those the corneal nerves and the trigeminal nerve, they actually go to areas of the brain that are responsible for emotion. That's why some of our patients that are dealing with eye pain are so emotional. So we have to understand that there's a component of that to it as well. Now, these patients may also need lifestyle changes. They may need to improve their sleep habits, decrease stress, exercise, massage, acupuncture, cognitive behavior therapy, and treat any untreated anxiety and depression. Things like this will help kind of reset that central nervous system so they're not perceiving all the pain that they are currently perceiving. So you can try to decrease pain by helping that central nervous system out. So in summary, I think we need to start thinking more about the corneal nerves, especially when things aren't adding up. We need to think about neurotrophic keratitis. If we have unresolving corneal staining or defects, when there's a lot more signs than there are symptoms, so a lot more looking dry eye, but the patient's not feeling that dry eye. We need to know what the risk factors are, like diabetes, prior herpetic infection, history of eye surgeries or brain surgeries. And we need to test corneal sensation to be able to tell, is there reduced sensation? And if there is, that's diagnostic for neurotrophic keratitis. And then neuropathic pain. These are when patients have way more symptoms than they do signs. We need to see, do they have allodynia, so pain when there shouldn't be pain, or hyperalgesia, exaggerated pain response? And do they have any risk factors like chronic pain syndromes, fibromyalgia, history of certain surgeries, migraines, things like that? Our patients can be anywhere on this graph here. They can come in with dry eye, no dry eye, neuropathic pain, neurotrophic pain, or neurotrophic keratitis. So again, no pain there. But we need to try to figure out where they're coming in. So we need to understand they could be anywhere on this spectrum here. And it's our job as the doctor to figure out where they actually are. So I'll leave you with this. be kind, for everyone you meet is fighting a hard battle. Whether or not your patient is suffering from just dry eye, that's hard on them. That affects their quality of life. It affects them financially getting these drops. Whether they could have a neurotrophic keratitis, and that's affecting their vision, and that's difficult for them. And neuropathic pain, these patients are fighting very hard battles, not just ocularly, but systemically as well. And a lot of times these patients have anxiety and depression and poor sleep and all these other comorbidities as well. So these are my references. This is my family of three. So that's me with my daughter, Eleanor, on the left, and then that's my wife, Megan. And we are actually going from a family of three to a family of five. We're expecting twins come in September 2024. So we're very excited about that. All right. Well, thank you very much for letting me present. Does anybody have any questions?
Thank you so much, Dr. Kaleb, and congratulations. That's news, and happy for you and also the family. Yeah.
Yes, thank you very much.
Yeah, great. So you would be busy in all of that, and thank you so much again for spending the morning with us, away from the family time as well. So much of information, which is really something which it's kind of like myopia, I would say, where we don't know a lot about myopia, and same thing goes for dry eye as well. I mean, the pain part of dry eye assessment is neglected, as you were saying. So it's really something which we need to figure and look forward to when it comes to assessing that.
Yeah, I totally agree. I don't think we understand dry eye well at all. And I think the best way to understand that we don't understand dry eye well is we can't come up with any sort of test that correlates signs and symptoms. Even with decades of research, we still don't have a test that can predict whether or not our patient has symptoms. And that to me just says we don't understand this condition very well.
That's right. Yeah. So I think with all these information, putting bits together, not neglecting the pain side and, neurologic examination kind of really helps us to make some decisions better than just prescribing always the artificial tears and warm compress. I mean, we need to know what type of pain and, tailor the treatment based on what the patient is actually suffering from.
Yeah. And I've wasted a lot of my time, and I've wasted a lot of my patients' time trying to treat something incorrectly. Like, trying to throw artificial tears on an eye that's not actually dry, but the patient thinks that they have dry eye. But then you look at their medical history and you realize, wait, they have all these chronic pain syndromes, and they don't sleep very well, and they have they're stressed, and they have anxiety and depression, and artificial tear is not going to solve all that. We have to try to address some of the underlying causes there.
Right. Yeah. One question I think which came into me earlier when you were talking about testing of making sure that we are testing the nerves, the corneal nerves, when you mention about the aesthesiometer and the tissue or the dental floss and all that. Would you do it on all your dry eye patients, or are there a subcategory of patients which you would definitely do it, or you prefer to do this on all patients?
I think ideally you would do it on every patient, but we're all busy. We all have a lot of patients to see. So I don't test it on everybody just because I don't have time, unfortunately. But I mean, if you really wanted to be thorough and serve the patient best, ideally you would test on everybody. But really, I'm trying to see, do they have risk factors for neurotrophic keratitis? Have they had LASIK before? That's a huge one. Did all of their dry eye start 3 months after a cataract surgery? Then we know in cataract surgery, you make 2 incisions. And when you make those incisions, you're severing a lot of those nerve bundles. And again, just hoping that it grows back normal. So I'm looking at their history, and if they have any risk factor for neurotrophic keratitis, my ears are kind of perked up a little bit for NK. And then especially if they are complaining more about blurry vision, less about dry eye, but they just say, I just have this constant blurry vision, my eyes feel fine, then that should kind of raise your level of suspicion that there could be a neurotrophic keratitis involvement there.
Yeah. And somebody was asking about the pain visual analog score. anything in terms of the pain score, like how we said the dry eye symptoms may not relate to the dry eye signs. Have you seen any influence of the symptoms of pain versus the signs of pain? For example, when you're doing the confocal microscopy, you see a lot of nerve endings which are exposed and things like that. So, any sort of clinical guidelines in pain score versus the signs?
So it's hard, and neurologists struggle with this, and anesthesiologists struggle with this, and we in eye care struggle with this. There's never a lot of signs of a neuropathic pain because the whole point is that the problem is much deeper than the epithelium. So you never really, unless you have access to a confocal microscope, which there's only like 20 of them in the United States, and we're fortunate enough to have one. I mean, so almost nobody has one of those. But unless you have one of those, you're probably never going to see a sign of it. So you rely on what the patient is telling you usually and what their risk factors are. So I like to do a survey called the Ocular Pain Assessment Survey, and see what their answers are to that. And that can kind of clue you into whether or not they might have neuropathic ocular pain, and then just doing a very detailed history to try to understand if they have any risk factors for it.
Yeah, yeah. Always there is a problem of signs versus symptoms. I think most of the conditions have that issue. Awesome. There's one question. I think somebody has a similar scenario of a patient where they have a patient who has unexplained pain in the eye, and the ocular health looks quite normal. There's a little bit of early meibomian gland dysfunction. So they started with, lubricants and warm compresses. The pain didn't improve. It's the same. And the test which you mentioned, the proparacaine test, seems that the pain has decreased. So somebody wants your opinion on what should they do. Should they go ahead with cyclosporine, or prescribe them with the oral drugs as well? Okay.
Yeah, so it's great that you caught some of the dry eye and started treating that, because that's the first rule. You always treat any nociceptive or dry eye pain first, because if you don't get that under control, then you're going to be in trouble. So yeah, you always want to treat any ocular surface disease that's there and any dry eye that's there first. Now with the proparacaine, the pain decreased. So I would try to get a better idea of how much it decreased. Was it 100% better? Was it 50% better? So try to get an idea of just how much it decreased. But if it did decrease with proparacaine, then that again leads you to believe that it's something more at the level of the corneal nerves. So try to figure out, do they have any risk factors for neuropathic pain? My guess is this patient will have some risk factors for neuropathic pain, because there's unexplained pain. The dry is very mild. Didn't get a whole lot of improvement with dry eye treatment, and pain decreased with proparacaine. So it's probably a peripheral neuropathic pain. So what to do there? So cyclosporine will decrease inflammation, which is a great thing. We don't want there to be any inflammation there, because that can make the pain worse. So cyclosporine is not a bad option. If you have any sort of option to get them like a nerve growth factor, so if you have the ability to get them, eye drops made from their own blood, that would be a really good treatment. I don't know how available that is where you're at. Even in the United States, it's hard to get in a lot of places. There's a lot of places that don't know how to make it still, which is frustrating. But if you can do a blood-derived product, that would be a great thing to start with. If you can do an amniotic membrane, there are, factors in there to help support those corneal nerves in an amniotic membrane. So you could try that as well. So doing anything you can to support those corneal nerves, with a blood-derived product or an amniotic membrane would be very helpful. The cyclosporine to decrease inflammation could be helpful as well. Now, gabapentin, it's an oral medication, obviously, although sometimes I'll have a local pharmacy compound it and make it into eye drops. But I mean, generally, it's an oral medication. And so that will help systemically. So that's usually more of like a central neuropathic pain. But if you don't have options to treat a peripheral neuropathic pain, like a blood-derived product or amniotic membranes, then oral gabapentin still could be helpful because oral gabapentin should reach the level of the corneal nerves as well. So I would try to tailor your treatments towards the corneal nerves first, but if you're limited in your treatment options, an oral gabapentin or pregabalin could still be helpful. I've had some wins with my patients doing something like that, even though it wasn't a central neuropathic pain, it was a peripheral.
Wonderful. Right. So I think that's very important to understand where the problem lies and, step-by-step management, treating dry eye first. And then, the center is get them comfortable and get the inflammation out first and then move ahead with other remedies as well. Wonderful. Great. So I think with that, we have taken a few questions which popped up on the chat. Thank you so much, Dr. Kaleb, for joining us again this Sunday morning and, sharing all of that neurotropic keratitis, neurotropic pain, dry eyes, and all of that information, which I think is really very important to understand our condition very better. So thank you so much for sharing that with us.
Of course.
We do have session planned for the next couple of weeks. So thank you so much, everyone. Take care, be safe, and I hope to see you during the upcoming sessions. Thanks and bye.
Bye.
Have a good day. Take care.